All right. Welcome. Very, very pleased to be here. Good morning, everyone. I'm Chris Mushquash. I'm a psychologist and professor in the Department of Psychology at Lakehead University, and as well as the Northern Ontario School of Medicine University. And very, very pleased to be moderating this Gairdner Global Perspectives panel on Indigenous health. It's a particular honor because both of the panelists here are Indigenous scholars who I've always aspired to be like, and so it's a very, very meaningful day for me as well. I'm originally from northwestern Ontario. I grew up in a small town. My First Nation is called Pugwashing First Nation, Pays Plat. I hold a Canada Research Chair in Indigenous Mental Health and Addiction. Since we convene here in Vancouver, BC, let's take a moment to honor these lands that we're on. We're on the traditional territories of the Musqueam, the Squamish, and the Tsleil-Waututh nations, acknowledging this connection to the region. And as I always try and do, is to encourage people wherever you're from to think a little bit about your place and your place or that place and your relationship with it, as well as the relationship of the people who call that land theirs. So this session is a pivotal moment to engage with the complexities and nuances of Indigenous health through the expertise of our renowned panelists. Today's discussion is set to explore the vital importance of social and cultural determinants, intergenerational trauma, the principles of self-determination and reciprocity in Indigenous health research. Our goal really is to deepen the understandings and enhance our approaches to health research in Indigenous contexts, aiming for respectful, informed, and improved outcomes. Today we have two panelists. Our first panelist here is Dr. Nell Wieman, Chief Medical Officer at the First Nations Health Authority in British Columbia, with over 2 decades of experience and Canada's first female Indigenous psychiatrist. Dr. Wieman's extensive work across clinical, academic, and leadership roles exemplifies her dedication to improving Indigenous health outcomes, and her insights today, I assure you, will be invaluable. As well, we've got Dr. Jeff Redding, holding the BC First Nations Health Authority Chair in Heart Health and Wellness at St. Paul's Hospital. With a career dedicated to enhancing Indigenous knowledge and practice, Dr. Redding's contributions have significantly influenced Indigenous health research in Canada and globally, and his expertise will be crucial to what we talk about today. So let's move forward and commit to engaging deeply with the knowledge and perspectives shared by both Drs. Wieman and Redding. Contributions will help guide us in effective, respectful, and culturally informed health research practices. So, welcome. I thought the way that we could start is actually to sort of turn it over to you each in turn to tell us a little bit about your life's work and some of the key issues that you're working with and some of the key insights that you think that people need to know about.
Great, thanks, Chris. Bonjour, Ani. My name is Nell Wieman, Indigenous. I am Anishinaabe originally from Mishi-Bawitagong First Nation, which is in Treaty 5 territory, part of the Anishinaabe Nation. So now I live, work, and play on the traditional, ancestral, unceded, continually occupied and stolen territories of the Coast Salish people, including the Musqueam, the Squamish, and the Tsleil-Waututh Nation. And it's with great humility that I am an uninvited guest on this territory, and I get to do the work that I do now. Chris probably minimized in the sense that I feel like I've been around forever. So yeah, it's hard to share all of my life's work with you, but I will say that what I have tried to do my entire career is to serve First Nations and other Indigenous communities, including Métis and Inuit, and try to be a part of a process that results in improved health and wellness for Indigenous people across the country. And that's no small task, and I think all three of us here on the stage, and probably many people in the audience, are also a part of that work. I started my career, as Chris mentioned, as a psychiatrist, working clinically on the Six Nations of the Grand River Territory. And that experience, in addition to trying to be of service to that community, really made me think a lot about health disparities, gaps in health status, but also the gaps in health service provision to First Nations people, and not just access, but racism involved in the healthcare system. And I experienced it many times myself, and I've experienced it throughout my life. And I think part of what we need to talk about when we're talking about Indigenous health research, for example, today, is to kind of lean in a little bit to that discomfort and acknowledge that racism, systemic racism, and white supremacy has been a part of the health system and the way that it was designed. For example, I'll tell you, I had a patient who was, I would say she was kind of mischievous in her life. She'd had a lot of adventures, but we had worked with her, helped her stabilize. She was pregnant, she had a substance use disorder, and she gave birth in hospital. And the first people that she called were myself and the nurse who was working with her. And we had prepared a little gift basket for her. It was part of that holistic way that we have as First Nations people of wrapping people in love and care. And so the nurse and I showed up at her hospital room to visit her, and it was maybe 4 or 5 hours after she'd given birth. And the staff at the hospital called security on us because I was dressed very casually, so was the nurse. And they thought that we were her girlfriends bringing her drugs to her hospital room. So those types of stories, I could tell you 100. And so it got me, those types of experiences got me thinking about, well, what more in a broader sense can I do to contribute to Indigenous health? So I left clinical practice for the most part. I maintained a small clinical practice in downtown Toronto. And I spent about 7 years working in the Dalalana School of Public Health at the University of Toronto, along with Jeff, who at the time, he'll give you a little bit of his background, but he was the scientific director of what was then called the Institute of Aboriginal People's Health, which is now the Institute of Indigenous People's Health. And we worked on a couple of things, both research directly. My major area of research was First Nations youth suicide, and also training the next generations of Indigenous health researchers and supporting them. So Chris mentioned, for those of you who were in his talk just previous to this panel, about the 7 generations. And that is a sort of a universal teaching where we realize that we are the product of 7 generations. So even though the 3 of us are here on the stage this morning, all our ancestors are behind us here with us, holding us up as we talk about some of these very challenging issues and having difficult conversations at times. And then what happened was I ended up in clinical work for another 10 years before finally moving to Coast Salish territory and taking up my role in public health. I should say that I've been here for just over 6 years and switching from psychiatry and some academic work into public health about 1.5 years before a global pandemic is not necessarily the best career choice. So those 2.5 years were a bit of a blur. But now, as I said, it's an incredible honor to serve. I've had a couple of different roles at First Nations Health Authority. And it's been an incredible honor to now serve as the Chief Medical Officer. So in brief, because I'll pass over to Jeff, and I think we're going to have a great conversation here this morning. So First Nations Health Authority is it's the only provincial health authority in the country that is meant to work with and on behalf and for First Nations in British Columbia. So we have 204 First Nations communities that we work with. British Columbia as a province and our health authority is also subdivided into 5 different regions. And so we have regional teams that we work with. I work in sort of the central part of the health authority, but we do a lot of engagement with our communities in the regions. And health research is a priority for First Nations Health Authority. Part of our role as in the Chief Medical Office is to be what's called watchman. And that's based on a Haida nation and other nation legend where if you can picture a totem pole. I wish we had some slides. There are 3 figures that sit on top of a totem pole facing outward. And so these were usually placed at the entrance to a village or a community. And so if you imagine the 3 people facing outwards, the 3 watchmen, one of them or 2 of them can watch for dangers or risks approaching the community, and they chatter amongst themselves, and the 1 or 2 that face inward to the community communicate that risk and danger to the people from that community. So that's one of our central roles. That's one of my central roles at FNHA. And part of that watchman role involves reporting on the health of BC First Nations people. And partly how we do that is through research. So there, Jeff, I think, will speak a little bit more about some of the perils of health research for First Nations and other Indigenous people. I'm using the word First Nations because that's the organization that I represent. I think some of the other things that I'll just raise and then I will pass on is I think there are a lot of very motivated, well-meaning researchers who want to do work in the area of Indigenous health research. They want to be a part of doing research that benefits Indigenous people, First Nations, Métis, Inuit, and has real significance for improving health outcomes. And I think sometimes that process goes awry. And for me, I think Jeff will talk more about communities directly. But so for example, one of the things that I notice quite a bit, and it usually will happen on a Saturday morning, is I get up early, I get onto my computer, do a few emails, whatever. And honestly, at least once a month, I'm not exaggerating, there'll be an email from a researcher, non-Indigenous. Dear Dr. Wieman, I know all about you, I've read about you, I've got this CIHR grant that's got to go in by Monday. I really want you to be a part of my research. Could you just fill out this form and sign, and what's your CIHR PIN and your CCV number? And you know, it's all good, right? We're good, right? And I'm like, no, we're not good. Like, I've never heard about you. I've never known anything about you. I don't know anything about your work. And people can be quite demanding because, you know, I get it. They have careers to build, they have tenure to achieve, et cetera, et cetera. So that's one thing that comes across as somebody who has worked in research. I'm a part of research. FNHA holds several CIHR grants. For example, we're looking at the after effects of the COVID pandemic and how that has impacted First Nations in BC. But that's something that happens quite a bit, that sort of engagement process, and maybe we can talk about that a little bit more in the discussion. The other thing I'll just quickly mention, and then I'll pass on, is you know, the whole issue around data governance. You know, whose data is it anyway? It's First Nations people's data in BC, and part of the role of the Chief Medical Officer is to be the data steward of that data. So we try to be quite selective about who we engage in research with, trying to understand the intention, the purpose, the potential impact, the unintended consequences of some of those research projects. And of course, we use data in all sorts of different ways, not just research, but in surveillance, for example. In British Columbia, we are in almost the 9th year, starting the 9th year in a couple of days, of a declared public health emergency in this province, which is the toxic drug poisoning crisis. So we take First Nations data, which is in what's called the First Nations client file. We link it with vital statistics and a database from the BC Coroner Service, and we know on a monthly basis how many First Nations people die of a toxic drug poisoning on an ongoing basis. So I think I've raised a whole bunch of points. I'll stop there. I'll hand over to Jeff, and I look forward to a great discussion.
Thanks so much, Dr. Wieman. Dr. Redding?
Yeah, I don't know about you, but I could listen to Nell Wieman talk all day long.
Yeah.
My name's Jeff Redding. I'm Mohawk from Tyndonega, which is a reserve First Nation on the north shore of Lake Ontario. That's part of the Haudenosaunee Six Nations Confederacy. You'll know that if you study a bit of Canadian American history, that the Mohawks were partnered as mercenaries, I think it was, in the American Revolution in the War of 1812, and actually played a significant role in how this nation state was created. And the border between Canada and the United States was determined by the conflicts that happened in 1812. We actually, Canadians, British, burned down the White House, as you might recall. In any event, that's why you'll find Haudenosaunee people in upstate New York, in the province of Quebec, and in Ontario. And so my ancestors went to Tyndonega, and Chief Deserondo, was a captain in the British military, along with Joseph Brant, who was the chief of Six Nations. 17 families went to Tyndonega, and so I'm a descendant of one of those 17 families. I'm also born in St. John's, Newfoundland, so I'm a Newfie Mohawk. Is that politically correct? At the present time, I'm very grateful to be able to work, live, and play on Coast Salish territory. I live in the Lekwungen-speaking territory on Vancouver Island in Victoria. And for the last 8.5 years, I've been the First Nations Health Authority Chair in Heart Health, at St. Paul's with support from the Heart and Stroke Foundation, and based in the Faculty of Health Sciences at SFU. It's previously, back in the early 1990s, I did my Master of Science and PhD at the University of Toronto in the Nuclear Cardiology Lab of Peter Liu. And I was a mainstream researcher doing clinical research and looking at patient care in heart stroke or heart failure and post-bypass surgery. And I was at the Faculty of Medicine in the Department of what they called, hygiene, I think it was, public health, before the Wabak and Ness Bryce. And I basically was working with Diane Longboat, who's this woman from Six Nations, who established a health careers program. And I got to know a lot about Indigenous students because I was tutoring them in math and science through this health careers program. And then I started to read the literature on Indigenous health, on the side of my other work. And I was, frankly, I couldn't believe it, because all my training prepared me to look at statistically significant differences between groups, If you could show, a 5.05% statistical significance is 1 in 20 chance that they're different, that was going to be acted upon. And it wasn't really my job to act upon it. I could just do the research, take it to a conference. We saw, and we still see, profound differences, like we heard about this morning, 6 to 20 times higher prevalence rates in different conditions that we know predispose to illness. And we also know that there are treatments and care that can be offered to patients and, to prevent, to care for, and to rehabilitate people who have these conditions, And it was completely being ignored. Around the same time, the Royal Commission finished its work, Royal Commission on Aboriginal Peoples, and it actually produced volumes of information. First time that people went out to communities, like a commission with Indigenous leaders, and talked to communities about their concerns, and it got reported into a 5-volume, and that provided a real roadmap, for looking at actually where to begin. And they talked about everything around Indigenous life. So, the timing actually couldn't have been better, because here was this document. And you might also recall that the Oka crisis sort of happened. There was a kind of a military intervention because Mohawks had decided to defend their territory. because they wanted to expand a golf course over the grave sites of Mohawk people. And that in turn created a response where the military was called out, and then Ganawage, south of Montreal, joined that effort with Oka, and they closed the Mercier Bridge, which is a big transportation route to the South Shore in Montreal. So that whole summer in 1994 was a sad page of Canadian history, where elders were abused, and there was a lot of violence perpetrated against Indigenous people. So, being First Nations myself, I couldn't ignore what was happening around me, the data, but also the civil unrest and the racism targeted towards Indigenous people in particular, and a lot of the things that people said about Indigenous people during that era were very difficult to reconcile, So, and that I chose that word carefully because reconciliation is a big part of what we're talking about here today. Fast forward, I decided to kind of ditch my health services career and look at in physiology and that, and go into, I shouldn't say ditch my health services career, but go into Indigenous health research permanently. And Ellen Bernstein actually hired me as the founding scientific director of the CIHR when it started. And that was a really important turning point. The first thing that we did was build a capacity opportunity for students, Indigenous students, to gain advanced degrees. And one of the people that we supported, and actually Chris Mushquash won the national award as one of our top doctoral students in the early years of the CIHR, and that was a Scientific Director's Award. The second thing that we did was develop a set of ethical guidelines for the conduct of research, and that was to be able to kind of actually address some of the ethical concerns around research, but it was perceived differently. Some people saw it as barriers to conducting research in Indigenous communities. Other people, our intention was to actually enable research by creating a common set of guidelines so that people knew how to approach communities, because we knew that scientists were interested in turning their attention to Indigenous health, but they knew it was complex and sensitive, and they had nothing in their background or training to prepare them to approach Indigenous communities. And certainly in their upbringing, many of them had never even met an Indigenous person. So these guidelines were setting out a way to kind of approach communities and to be able to look at that. And when we put those guidelines forward, the Scientific Council at CIHR, comprising all the scientific directors and the president, voted unanimously to kind of pursue that. It was a 5-year initiative. It wasn't a slam dunk. It took a lot of consultation. And now Wieman here, Dr. Wieman was on the governing council that brought that document home. So we're really thankful for that, because public policy in the area of ethics is extremely important so that it can actually enable research to take place. And I just wanted to take a few minutes here just to explain a little scenario that I think has a happy ending. Back, there was a time when this Dr. Rick Ward, he was a professor at UBC in the Department of Genetics, and he went to a tribal authority on Vancouver Island called the New Chalmers Tribal Council, 13 First Nations, all coastal First Nations. They had a very bad problem with arthritis, bone disease, and actually worked in the lab right next to Rob over there. And, so he actually collected the samples, and a lot of people wanted this research because they were in pain. It's a very prevalent problem in the community. Anyway, he collected these biological samples, and then he went from UBC to Utah, and then from Utah he went to Oxford, where he became the director of the Center for Biological Anthropology. So he was actually, then he published papers on the New Chalmers, addressing the hypothesis of, migration from the Siberian land bridge to the coast of BC, and he put forward the hypothesis that they were actually this sort of migration pattern using genetic data. Of course, he had never obtained any informed consent for that, and what happened was the New Chalmers got wind of it, and the local community newspaper published the first story. It was picked up by the CBC. Rob became quite involved with Laura Arbor and a number of people. The chief and council and the community was involved. What happened there next was, we got it became an international bad practice known as bad blood, and it was published in Nature and Science as a way to not conduct research in Indigenous communities. And what happened was those samples were eventually returned, and Rob helped to do that as well, back to BC, and they were disposed of in the community in a ceremony by elders. But the story is not over there, because it would be quite understandable if the New Chalmers said, we're not going to have anything to do with researchers in the future, especially people who will take our biological samples and lie to us. What they actually said was, we are always excluded from, research projects. We want the research projects, but we don't want them conducted in a way that respects our ways of knowing, and we want to have control of those ownership, access, and possession of those samples. And so more recently, we got 2 big projects funded. One is Developmental Origins of Health and Disease, where we look at maternal child health and study the cohort over the next 15 years. It's being led by this health director of New Chalmers, Lynette Lucas. She is the principal applicant at CHR. So that project goes through SFU. The second one more recently was a COVID-19 vaccine efficacy study and safety study, where the Public Health Agency, through the Immunity Task Force, directly funded New Chalmers through the health director to undertake in partnership with the National Microbiology Lab in Winnipeg. So blood samples were collected. It was under community control. We had over 90% compliance with venous blood sample draws, and because it was a situation where we were working together and there was trust that was built. The blood samples were brought to Winnipeg. We had someone called a data sort of sample guardian, a biological sample guardian, who was part of our project from the community, accompanied the samples to Winnipeg, learned the procedures, was able to get security clearance, which takes quite a long time actually, and brought the samples back after they were analyzed, and they were treated appropriately by the elders. That woman who was the biological sample guardian is the daughter of the health director, and she had a degree in microbiology, applied to medical school, and is currently doing her first year in medicine at UBC. So, it's an interesting odyssey, right? That you can kind of go through this pathway, and it's kind of, to me, like a story about healing, and a story about how we can work together in a way that supports community aspirations. We meet the standards of community relevance, but we also look at the pursuit of scientific excellence according to international standards of excellence that we all, because bad science is not what communities want or desire. They want good science, the best science available, but they want it to be in a way that is not harmful in the future. So I just wanted to share that with you, and I think I'll just stop there because like Nell and Chris, we could go on forever if you give us a chance. So thank you very much.
Congrats. So on behalf of everyone here in the broader communities we all come from and represent, I want to extend our deepest gratitudes to Dr. Wieman, Dr. Redding, for their contributions to the panels today. Enriched understandings, certainly by me and hopefully for you as well, but also highlighting pathways forward towards better practice, more equitable and effective research in community. Now looking forward to opening the floor to questions from the audience, moving into the Q&A portion of the session. So it's an opportunity to delve deeper into themes, ask questions about what you've heard, or questions about what you may be wondering about. For those wishing to ask a question, you've been provided a cue card on your chair to write down your question confidentially. Once you've written your question, we ask that you wave down one of our volunteers. I understand there's a volunteer who will collect those. So to ensure a diverse range of topics and respects everyone's privacy, we're going to select and read submissions, and it'll allow us to address as much as we can in the remaining time. So yeah, we're hoping as we prepare this session, let's continue our approach to approach our discussion with respect, curiosity, openness, aiming to foster a meaningful dialogue that respects confidentiality and sensitivity. Thanks in advance for your thoughtful questions. Looking forward to it. So are there cards somewhere? Okay, if you raise your hand, your card will be picked up. Maybe as the cards are arriving, we've heard themes of treatment for Indigenous people, and in particular racist treatment. One of the things I'm quite interested in research is in addition to that, is sort of like how institutions sometimes behave in manners that aren't necessarily, purposefully racist, but are certainly institutionally biased and racist in effect. And so I was running a research project that was in collaboration with 10 First Nations communities, all remote in northwestern Ontario. And part of the desire of our HR and our REB was to not send any individual into any community by themselves, because that could be very dangerous for that individual. And people were research assistants were largely non-Indigenous. We didn't have as many Indigenous students and trainees at the time this project was on, and so we were able to kind of make an argument, and communities respected that there'd be two people coming at once, and it actually worked better methodologically. But the other question that I had to respond to was, suppose one of these two individuals has some kind of medical difficulty while they're in a remote community. What are you going to do about that? What are they going to do if that happens? And my response to the institution, of course, was the same thing the other 700 people who live there have, right? And that is a nursing station where you can see a nurse, and if the nurse requires additional help, then they have access to an on-call physician that they'll speak with. And if they need more help than that, then there'll be a medical evacuation out of community and brought to a larger center. But it's interesting because the institution imagines that somehow the two people going north should have access to better health care than the 700 people who live there. And so you kind of run into these things that are like these kind of strange institutional beliefs and systems. And I'm sure both Dr. Redding and Wieman could write books on this. I'm collecting in my head a little compendium of them, and I hope to someday write like a humorous book about it, because if I like humor, and if you don't use humor, then you'll just be angry all the time, or I'll be angry all the time, I find. But I think that in addition to kind of clearly racist behavior at the individual level, we have these systems that somehow privilege certain lives over other lives, and don't even really think about it. And I think that that's an issue that I've certainly experienced quite a bit. I don't know if you've got reflections on that.
Yeah, I think, while the questions are coming in and Chris has a chance to have a look at them, I also should just preface my comments by saying my thing at the microphone a couple minutes ago is I'm suffering from terrible seasonal allergies. So visitors to Vancouver know we're at the end of cherry blossom season, but there's still some out and about that are just, anyway, I'm full of seasonal allergies. So I apologize if I sneeze. Part of the work that we do at FNHA, and Jeff actually mentioned the research chair position that he has. We actually have we sponsor 3 research chairs at FNHA. One is a chair in nursing, and then in our office we have Jeff, who is the research chair in heart health, and then we have another chair, the First Nations Health Authority chair, which is a partnership with UBC on cancer and wellness, that's held by Dr. Nadine Caron, who's not able to be with us today on this panel. So we have these endowed research chairs. We're involved in a whole bunch of different initiatives. We were also involved in people who live in British Columbia and maybe outside of British Columbia may now be familiar with the In Plain Sight report that was triggered in the summer of 2020. The final report was released. You can find it on the Ministry of Health of British Columbia's website. And that explored racism in BC's healthcare system. And it's something, for example, that BC First Nations people know all about. But this was kind of a large-scale survey of Indigenous people in the province that confirmed the types of experiences that they've had trying to access healthcare. And we noticed quite a bit, for example, during the COVID pandemic, that access, when we talk about access to healthcare service, we're not just talking about a nursing station in a community, a bricks and mortars clinic with health professionals there to see people. We're talking about people being willing to come forward and seek access at those different places. And one of the major reasons why they don't come forward to seek access or even potentially participate in research is because of racism and out of a fear of how they're going to be treated. And so we have that In Plain Sight report that was, it was a research project that ended up being a report. You can find both the full report, which is quite lengthy, it's I think almost 300 pages, summary reports about 70-something pages, and the data report, which is extensive, all available on that website. And I think that's something to keep in mind as well. I keep using one chart that's in the data report in a lot of my presentations that shows the top 10 healthcare settings where Indigenous people feel the most unsafe, and of the top 3 are all related to mental health and substance use settings. So we know, for example, that people have a lot of stereotypes, a lot of bias, treat people in a discriminatory manner because of the stereotype around, all Indigenous people have substance use issues. And that's the first thing that people think of when someone shows up in an emergency room. But we know that that's not true. But those settings are particularly fraught with Indigenous specific racism, not just in British Columbia, across this country and other countries that have significant Indigenous populations.
Thank you very much. Any other thing to add?
You got a lot of questions.
This is
that's a lot.
remarkable. And I will say, given a number of physicians and/or aspiring physicians, these are all very legible. So thank you for that. I'm trying to do a bit of a principal components analysis right now for any of you stats nerds. But there is a little bit of overlap in questions, so maybe we'll start with this latent variable. So these 2 questions sort of talk about what are the best practices to engage communities in health science research or co-design of research. So I'm wondering if you have some thoughts on determining needs for research, co-designing, how to go about doing that, and in addition, engaging Indigenous scholars in the process. One person acknowledged that it's not the job of Indigenous scholars to educate everyone else. However, in the absence of a knowledge of an approach, what would be the best way? So maybe a multi-part question. First, engaging in research, but also engaging Indigenous researchers.
Do you want to start?
Okay, I can start, and just wave to me if I go too long. One thing that we did with the ethics guidelines, which is quite unique in the world when they came out, was the history of ethics in research protects individuals, informed consent, and what made these guidelines different is that they looked at the collective, or the collectivity. The entire communities were being stigmatized by research in negative ways as Dr. Wieman just described. And communities were sick of it, you know, they called that research to death. And so the notion of getting informed consent from communities around the interpretation of the data was an important component of those ethics guidelines. Now, I just take you fast forward 25 years to what we're doing now. It's about distinctions-based research, and distinctions is it's a very descriptive word. Each community is distinct. They have their distinct language, cultural history, ways of engaging, music, dance. They, to compare the Haida to the Mohawks to the other tribes, the Cree or the Ojibwe, it's like comparing people from Turkey to Ireland, to Scandinavia. There's quite a bit of diversity. Even in the province of British Columbia, it's the most diverse part of the country. We have over 200 First Nations. They're all different. So having one pan-Indigenous approach that's going to serve all communities in the same way is I can see the reason why people would want a practical recipe book to follow. We can't give you that. It's about a process of engagement and reciprocal exchange of information, getting to know the communities that you're working with. And what we've done with the Institute and other things like the FNHA is try to be that broker, to have that engagement to happen, to create a safe space where we can actually work together around. And that is what reconciliation is about. It's about, we don't need to change. We actually need mainstream society to change so that we can undertake this kind of engagement on a nation-to-nation basis. And that includes First Nations, Inuit, Métis, but it also includes subpopulations within those urban, rural, remote, isolated. When you start that process of engagement, people like Laura Arbour, who's a geneticist, Dr. Arbour, has done the Silent Genomes Project with Nadine. And, it's been a reciprocal relationship where knowledge is gained in both directions. And I think you'll find if you start to think that way, it will be very enriching for you. And I think, think about distinctions and each community being distinct in the context of the Canadian kind of mosaic.
Yeah, I think to add a little bit onto that about, first of all, engaging with communities. At FNHA, for example, we have quite a robust engagement process. It's sort of ongoing throughout the year, but there are two big times in the spring, in the fall. We call them caucuses. As I mentioned before, BC we're split into kind of 5 different regions: Northern Region, Interior, Vancouver Island, Vancouver Coastal, Fraser Salish. And so each spring and each fall, the senior leadership at FNHA, we go to each region over a 5-week period, and we spend 3 to 4 days in community in a region, and then we go to the next region, and we do this in the spring and in the fall, and we hear from communities directly about, in this case, if we're talking about research, we hear from communities what they want to know about, the kinds of questions that they have. So for example, when I was talking about getting the Saturday morning last minute CHR request, it could be something very esoteric that the study is involved in. It doesn't relate in any way to anything that I've heard in working with communities that they want to know about. Right now, as I mentioned, we are in a different phase of the COVID pandemic, but that still weighs heavy on people's minds. We are, as I mentioned, on April 14th, which is tomorrow. I don't know the date today. Tomorrow will be the start of the 9th year of the toxic drug poisoning crisis being a public health emergency. Racism is another topic that people are interested in. Climate change and planetary health is a huge interest. And then there are others, chronic diseases, for example, as Jeff mentioned, in certain communities. They're wondering, like, why is there so much of this type of cancer in our communities? Why does everyone seem to have, a diagnosis of rheumatoid arthritis? So I think the first kind of step, if you're interested in health research with Indigenous First Nations communities, is to, we have lots of documents, for example, on our website. Find out what the communities want to know about. Because as Jeff mentioned, there have been many poor examples of research conducted with Indigenous communities where, Jeff mentioned, researchers have gone to the community, done their surveys, collected their samples, exited the community, and the community never hears from them again. They don't even see the publication that results from that research, never mind having a knowledge translation or a knowledge sharing event at the end of that research project. And there have been a couple of really good examples of how that's done well. I'm thinking of the Emergency Care of Elders project that happened in Port Alberni in the First Nations community that's adjacent to Port Alberni on Vancouver Island. I managed to go to that knowledge sharing event at the end, and as Jeff has also mentioned, it was kind of imbued both with, there was excellent knowledge that came out of that research project, but the whole sharing it back with elders in the community was done in a good way. It was steeped in ceremony. There were aspects of culture. We shared meals. We had the chance to interact one-on-one with each other. It was kind of a wise practice of how research can be conducted from start to finish with a community and do something that they're very interested in. The part about Indigenous scholars, engaging with Indigenous scholars. Yeah, I think there's, at this conference especially, there's a lot of similarities, I think, between Indigenous scholars who are interested in health research and Indigenous medical students, for example. And there are cases where, for example, a couple of years ago when I was the president of the Indigenous Physicians Association, we started a now regularly occurring survey of medical students across the country, Indigenous medical students across the country, and how they are experiencing daily life in those medical schools, including experiences of racism. It's called the TRC Report Card Project. And so it's similar in the sense that the medical students will often tell us, that they feel called upon by their medical schools to be the cultural tour guides for the rest of their fellow students and their peers. And that, first of all, is inappropriate to ask someone who's in a student role and put that kind of demand on them. And then, of course, it exposes them to all kinds of harms and creates, in some cases, unsafe spaces. So I think engaging with the Indigenous scholars, there are, and Jeff can probably even answer this better, because we were talking about initiatives that come from CHR that have programs that support Indigenous scholars and other ways that Indigenous scholars can be supported in terms of doing studentships and fellowships and developing their career so that they proceed through steps that don't kind of put them in situations where they're in over their heads or they're isolated from each other. And I think networking and at FNHA, we talk a lot about different communities of practice so that people have support with one another and ensuring that safety is there. I guess I'll...
Yeah, there's a lot of issues that we could talk all day about, I think. But I think to talk about the issue of racism just briefly, my doctoral student who's a professor now and directing the Center on Indigenous Governance at SFU is a partnership with FNHA, who actually worked for the Chief Medical Officer when it was Evan Adams and then Shannon McDonald, and knows Nell quite well. And she did her master's and undergraduate degrees in criminology and was doing work around policing the police, and looking at systemic issues within the police forces, and then turned her attention to the sort of journey in chronic disease and how people saw their treatment and care, the racism that they experienced in the healthcare system, how it prevented them from getting the right types of treatments in a timely manner. And so, you know, that's just one example. The CIHR has been a game changer, you know, because we focused on building a workforce. We have over 600 master's and doctoral, you know, graduates, Indigenous, that is working in communities and also in institutions. So it was a powerful intervention. And I was the chair of the peer review panel, and we look at CHR, we look at community engagement and scientific excellence as you have to meet both standards, you know, to be able to get funded through that panel. And we have something called iterative review and conditional funding. So if you submit an article or a proposal and it's Indigenous and it gets evaluated on scientific merit and engagement, if it doesn't meet those standards, then you get 1 year of bridge funding and then recommendations that you have to actually do to be able to bring those standards up. And usually there are community engagement deficits. And the committee evaluates the proposed plan, the revised plan, and it can go through a couple of iterations before they get the full grant. And one thing about researchers, they're very good at, you know, if they know that their money's on the table, they can adapt, and they actually get the resources. And what it does in a practical way, it takes excellent research and makes it outstanding, right? And I think that's what everybody wants to do. They want to do good research, excellent research, but they also want it to have an impact on the communities that's intended to change. So that's a model, I think, for other areas of interest, particularly patients with rare genetic diseases, you know, cancer survivors, patients with psychiatric disorders, like those other, everybody, you know, would agree that having client perspectives, patient perspectives involved in the decision making around advanced knowledge creation is a good thing, right? So there's a lot of things that we do in Indigenous health that I think can be transformative to mainstream. So that's something else to keep in mind.
Thank you. Thank you. I see we have about eight minutes left in our session, and so I wanna address these questions because I see them as very interesting together. So there's two questions that kind of aim at how can Canadian faculties of medicine better support Indigenous health or Indigenous cultural safety. We go 11:30. Oh, so we have lots of time then. Okay, good. All right.
Let's settle in.
All right.
Let's take your shoes off.
Put the tea on.
Okay, I'm looking at this clock then. I'll stop looking at that clock as you see me shifting all these. But importantly, you know, I have another question that's related, and it says, as an Indigenous medical student involved in advocacy and leadership at the faculty level, sometimes it can feel as an uphill battle advocating appropriate change when the responsibility is in the hands of only a few Indigenous peoples. Wondering about thoughts and advice about the extent to which faculty needs to take initiative and support Indigenous students in their challenging advocacy efforts, and what are some tips or advice the faculty could utilize to help our students. So I see those two questions. On one hand, you've got the institution saying, how can we help? And on the other hand, we have a trainee saying, I'm trying, but I'm maybe not getting the support that I need. And so I don't know if you've reflections on this.
Oh, I have so many, but I will try to keep it brief. I think, well, there's so many different levels of experience that I could share with you, just myself as a medical student, and that was like 100 years ago, and you know, sort of progressing through my career, and then working so much with students as part of the Indigenous Physicians Association. I think one of the things that really needs to happen, and I think it's happening to a certain extent at different medical schools across the country, is I think some of the senior leadership are not just becoming more aware, but are developing their own sense of cultural safety, and that includes being actively anti-racist. there's a great deal of variability across the country. So for example, you know, if you're tuned into the news, you may have heard over the last couple of weeks that Queen's University has made some, I think they're proposing and are establishing quite a different way of attracting students who may not typically have been included in the admissions process to medical school. They're revamping that admissions process to take a real equity deserving lens. And I saw an article about that on Twitter or X, whatever it's called now, and I rarely look at the comments of tweets because they're usually horrible, and to no surprise to anybody, when I clicked on that tweet about, you know, how proud Queens was of making these changes, it was really awful. The amount of negativity and racism that was on that line. So there are people, leaders, senior leaders in health, in medical school and health administrations across the country who get it, who recognize that equity is important, that Indigenous, First Nations, Métis, Inuit people have been systemically excluded from medicine and medical leadership, and that is changing as well. So we have amazing allies in this world across the country, again with some variability, and we have a lot more Indigenous, First Nations, Métis, Inuit leadership in medicine across the country now. A couple of years ago, I think now it's actually more 4 years ago, 6 Indigenous physicians, myself, Evan Adams, Sarah Funnell, Lisa Richardson, Marcia Anderson, Darlene Kitty applied and received funding from Health Canada to establish the National Consortium on Indigenous Medical Education, or ENZYME. And the goal of that organization really was to transform medical education across the country and be more inclusive and supportive, and mentoring was a big piece, and physician joy and work. I think, to my disappointment, there's a simultaneous session happening to this panel from that ENZYME group. It's really too bad that they were scheduled at the very same time at this conference. But having more Indigenous people in those positions of medical leadership is really important as well, I think, and starts to create a change. But I do see, you know, great allyship, great humility on behalf of some leaders, but not all. And that's, I think, the story that the TRC report card project that I mentioned earlier is really important, because it happens on a yearly or almost yearly basis, and really talks about sort of where some of the gaps are. And I think, as Chris mentioned, and I'll stop after this because you could see I could just go on and on and on. Sometimes I think we really have to disrupt the system of how things go. Like, it's so hierarchical, right? The whole system of medicine and health systems. And when the first time the TRC report card project came out, many of the deans across the country, and I won't point anybody out, and I hope some of you are sitting here, some were they were like, oh my gosh, great, thank you for this is very helpful. And some deans literally lost their minds. They were so angry about getting a report card from students, right? Like, the temerity of those students to actually give me a report card. It's like, wow, you know, some of that humility and seeing, I think a lot of the deans really think that change is happening. Every website of every medical school across the country has a TRC action plan or something, but how does that translate into the daily lived experience of Indigenous, First Nations, Métis, Inuit students across the country at these medical schools? And you'll see a lot of the times there's a big gap. And so the purpose of the project was to sort of try to build a bridge to understanding between those higher levels of administration and the students. And so that's just one example, I think, of.
It reminds me of I'm gonna tell you a story. So about half a year ago, I'd love to tell you I hurt my back doing something cool like mixed martial arts, but it wasn't. My little daughter, who's 4.5, she was putting on her t-shirt and one of the sleeves was inside out. and I leaned over to fix it, and everything turned white, and my back went out. And I don't know how I did that, but anyway, I did that. So I went limping into the hospital, because I'm a VP at VP Research at the hospital. So I went to the Senior Leadership Council meeting we have every week. And we've got a chief of staff there, and we've got a VP academic. So chief of staff's an emergency room doc, and VP academic is a surgeon, general surgeon. And so they saw me limping in. They said, "What happened, Chris?" I said, "I put my back out." And I said, "You got any of those tricks, like those ER tricks, where if someone sprains their finger with a wedding ring on, like the string, or anything for backs?" And they kind of chuckled. They said, latest review on backs is it's like Tylenol, rest. That's it. It's the best we can do. It actually outperforms any other intervention right now for backs. And I looked at them and I said, you know what? 500 years ago, right here, I would have got salicylic acid and rest. Are you telling me that the health system hasn't changed at all in 500 years? And they both looked at me, and the general surgeon said, well, we still cut holes. We just use shinier things to do it now, right? And so this issue of humility, I think, is an important one. Like we always imagine we're on the cutting edge, and we are on the cutting edge, and we ought to always be on the cutting edge. But just as we look back at what our professions were doing 20 years ago, 50 years ago, 100 years ago, we'll look back at this time, and many of the things that we'll be doing will seem absurd. And so the humility needed to take that 7 generations view of even our own professions, I think, is another thing that's an important sort of internal corrective mechanism when it comes to dealing with what can a medical school do with trainees, and what can Indigenous trainees can do. It's like, well, let's adopt some ways of thinking about things. I always say on the last day I retire, it's going to be like, gather around, kids, and hear the stories about how we used to sit in a room and interview people about their mental health symptoms, and then you would just listen to that, and you'd have them rated on a scale of 1 to 10, and then tell us again about how you'd put that in a spreadsheet and do analysis on it. Like, where we're going is unbelievable, but we're not there yet, and where we are is we always think we're doing the best, but we need to have humility to say there's other ways of doing things that we need to consider. Sorry, I just jumped in with a story. Jeff?
No, that was a great story.
Do you have comments?
I hope your back's okay.
Yeah, it got better. Yeah, I rest.
I've got some Tylenol. I just wanted to talk a little bit about the research, just to kind of counterpoint on the medical training, and it's kind of a similar thing. And I like to talk about the denominator and the numerator. What happens in, people talk about being researched to death, and what happens in Canadian research and evaluation is that every big project needs to have an Indigenous component to it, right? So you've got, 35 million people in Canada, and then you have maybe 5 million Indigenous people in Canada. So if you want to get a picture of Indigenous people for every study that's done on the 35 million, you have to oversample in the 5 million, right? And so, there was this story, the nuclear family was mother, father, kids, and anthropologist, right? And they were studying, that was something that happened in the 60s and 70s. People literally were familiar with people coming to communities to measure them and to weigh them and to ask them questions, and that was a constant thing. So one thing that happens in the dynamics is that you can go to any small town in Canada and ask people about research, and they won't know much about it, You go to any First Nation, Métis Inuit community, and people know a lot about it. They've been directly impacted by the research enterprise, multi-generational, So that means that people know about it, and they know about research ethics. And when you go to an engagement and people sit there, they know everything about you. And more than you could even, they know more about you than you know about yourself, I would say. They know about the research enterprise because it's actually damaged their communities, right? And so I think those are important things to remember. I guess when I was at the CHR with the 13 scientific directors at the beginning, I was a bit worried about those issues. And I'll have to say that, people like Rod McCormack, Alan Bernstein, Phil Branton, those are all the directors, the original ones in genetics and cancer research. they couldn't have been more supportive, you know, and, you know, there was a feeling there that just tell us what we need to do, you know, how can we support you? And I think that was probably the most encouragement that I could have, because I was like the youngest scientific director. These people were coming in being heads of departments and deans, and I was like paying off my student loans, you know. It was a little bit worried, but in any event, it all turned out good, I think. And so Canada has a lot to be proud of, but you know, we've done a lot. We're international leaders, but we've got a long way to go. And in some ways, the research continues to sort of pull back the veil of some of the things that are going on that were invisible to us before. And the sooner we can do that and reconcile those things, the better off we'll all be, you know. And I think planetary health, I think has been talked, that's about the intersections of all these health determinants, and that we're all in it together, be it, you know, climate change or the emergence of new diseases, or, you know, these are all things that I think COVID has taught us, that we all have to kind of take a planetary approach and think about, you know, working together better. I don't know if that's sort of a...
Yeah. No, it's helpful. I think that kind of leads into another question here that talks about, or that asks about what some of the biggest challenges you see facing progress toward healing and reconciliation, either at a national, provincial, or perhaps planetary level. Yeah.
I can start if you want. Sure. I'll be very brief. I would just say that policy, you know, like implementing policy and having the political will to make change. Like, we have the data, but sometimes, you know, people just ignore that data, and it's seen as being acceptable, you know, that this is the way it's always been, and yeah, there's disparities, but we can't do anything about it, and that kind of, so I think creating the political will to, you know, change. I'll stop there.
Yeah, I think to, I guess, continue on the theme, I was thinking about, you know, I was sharing earlier that one of my roles at FNHA as the Chief Medical Officer is to participate with my team and other teams at FNHA in reporting on health status. And so we have a big project that we partner with, FNHA partners with, here in BC, the Office of the Provincial Health Officer. And the Office of the Provincial Health Officer is Dr. Bonnie Henry. She's this kind of slacker physician, public health. She really doesn't do much, but she's not really busy whenever I need to talk to her. So Bonnie's office and our office work together, and we have this 10-year project called the Population Health and Wellness Agenda, which came out of some foundational tripartite agreements when the First Nations Health Authority was actually created, that we would regularly report on the health status back to BC First Nations communities. And so it's a 10-year project for now, and we have reports, it's kind of like the Olympics, big reports at year 1, year 5, year 10, and then smaller interim reports at year 2.5 and year 7.5. And we are just about to come out with the first interim report at 2.5 years. And that's an interesting project because it's so hard to capture on this panel how everything is kind of interrelated. Like, my mind is going a million miles an hour, but instead of just reporting on the very typical public health indicators, things like infant mortality, life expectancy, First Nations people here in BC said that's not good enough. We want to incorporate traditional knowledge, Indigenous knowledge. We want indicators that show our strength, our resilience, our ability to meet and overcome adversity. We want things framed in a more strengths-based way rather than a deficit-based way. And so I think Jeff was actually part of this project with Evan Adams, as he mentioned, was our former Chief Medical Officer, on a project called We Walk Together, where they worked with 3 communities in 3 different regions of this province, developing health indicators that will serve as kind of typical public health indicators moving forward that try to capture the extent and health benefits of people's connection to the land. So they were working on that. That report is actually coming out imminently in the next month, I hope. I was going to say a couple of weeks, but you know how these things go. You say it's going to be a couple of weeks, and then something inevitably comes up, like whole files get deleted or something. But so that's a different way of looking at it. And we haven't mentioned that two-eyed seeing approach yet in this panel. And some people really like using that term, and some people don't. But I think really what it encapsulates, and Jeff's mentioned it a couple of times, is not just, you know, achieving Western-based excellence in research, but also being recognizing the excellence of Indigenous knowledge. And as Chris mentioned, you know, the cure for a back going out was probably known 500 years ago, but for various reasons.
We have a Cochrane review now.
Yeah. And I'm sorry that you didn't heard it during MMA.
Something cooler, yeah.
Apparently there's a big pay-per-view tonight.
Oh, is there?
But yeah, anyway, I digress. So, for example, I'll leave you with one more example. So one thing that has really happened, and I've mentioned this a couple of times here in BC, is the toxic drug crisis. And we came out with a report about a month and a half, probably 2 months now, that because of our ability to access data and participate in data surveillance and have these data linkages, we have found in the province of BC that related to both the COVID pandemic but the toxic drug crisis, in which First Nations people are disproportionately overrepresented. So we represent about 3.3% of BC's population. We typically now represent about 16 or 17% of all toxic drug deaths in this province. And so what we found was, since 2019, our life expectancy as BC First Nations people has decreased by 7.1 years. The major contribution is the toxic drug crisis, with some contribution of the COVID-19 pandemic. 7.1 years. That's horrible when you think about it. And there are so many factors related to why that is, why we have those disproportionate numbers of deaths. There's a lot of stigma, discrimination against people who use substances in general. And then if you are First Nations or Indigenous, that just makes it even worse, the treatment that you receive. And so we are really in a difficult situation here in British Columbia where we're experiencing deaths. We talk about numbers, and I guess that's the other point I wanted to make before the end of this panel, is when we talk about health research, when we talk about research participants, when I talk about numbers of toxic drug deaths, to community, those are not numbers, and to me, to me, those aren't just numbers, and to Chris and Jeff, those aren't just numbers. Those are people. Those are people who are missing at dinner tables. Those are people who are missing in ceremony. Those are people who are missing as parents. We are now in a situation where it's similar to the HIV/AIDS crisis of the 1990s, where young children are being raised by their grandparents because that generation of parents are dying related to unregulated drugs. So then, to pull that thread back to what Jeff was saying at the beginning, part of what we're dealing with in health as well is political, and there's a lot of different influences as well in the media, for example, that continues to perpetuate stereotypes about people who use substances, because not everyone who dies has a substance use disorder. But we don't focus on that. The media always, if you turn on the Global BC tonight, you'll see a needle in a mud puddle in a back alley. You'll see someone living in a horribly disadvantaged, vulnerable situation. You won't see people like us who might have substance use disorders or be in recovery from substance use disorders, because we don't fit the stereotype of a First Nations person who has a substance use disorder. So I'm going a little off track, but to say these are the reasons why we need research, we need data, we need surveillance, so that we can report on these health issues. We need to do it in a strength-based way. Sometimes, though, the data is so glaring that what we can do is use it for advocacy purposes. So one of the things we've done in this province, because people come from all over to this conference, you may not know that we're heading into a provincial election here in British Columbia in the fall. So kind of people have decided to drop, hot potato items. As First Nations people at FNHA, we've decided we're just going to continue going, we're going to move forward, whether the province wants to come with us or not, in some ways, to continue to work on this toxic drug crisis, because it's related to everything. If we don't have those people in our communities, if we're losing people in the communities, that's going to impact 7 generations going forward. And
yeah, I mean, not to disrespect political processes, but I think platitudes are not helpful. Practical is helpful. When the TRC calls to action came out, 94 calls to action, 2014. There was this resounding, we're going to do all of it, and people cheered, and I thought, you haven't read it. Like, there's 94 of these things, and if you do 10 of them, it changes a bunch of other things, and this is very complex. Just to say yes, we can do it all, it just seems to me that it wasn't really thought through, and so practically speaking, how many of the TRC calls have been accomplished? Well, not 20, right? Maybe 12, 15, and there's a bunch in progress, and that was 10 years ago. And by the way, the regional engagements that took place to inform those calls to actions happened 12, 13 years ago. It's a long time. And so now we're still responding. Well, here's how we're responding to the calls to action, and you think, are those, if we did that now, would they be the same calls to action? Because things change as time goes on, and so these are real processes that affect people, and research has been very, very good, in terms of helping to identify some of these issues and be used to practically advocate in real time, in the moment, versus sort of in this larger political process that really doesn't privilege the needs of people in community or the needs of people who are experiencing disparate, health outcomes. I mean, we are achieving equity in life expectancy, right? But it's in the wrong direction. The general Canadian population is living shorter, right? So that gap's closing, but it's not closing in the way anyone wants it to close. And that's as a consequence of the toxic drug supply, COVID-19, chronic illness, and so on, right? And so, some of these conversations really have to be thought through. What are we talking about here, and politically, what are we going to do about these big questions? 26 seconds left. Any last things we want to say before
I'll just quickly say that I consider everyone in this room an ally now, so I'll be watching. It is about allyship, and every time that a file comes across your desk or whatever, you can think about, what can I do, to support this initiative in a respectful, thoughtful way, and it's kind of like a trickle-down effect. As Chris was saying, we're not going to see everything change overnight, but through individual, incremental, consistent efforts, the world will change, and that's what we're looking for, one person at a time.
Yeah, I think the only thing that I would add is, cultural humility is a lifelong process. One never gets to, just go one and done, now I'm culturally safe. And be actively anti-racist, and I know that's hard. If you see something, if you hear something, say something. I'll just be super quick. I was in a Zoom meeting months ago. Somebody on the call who was non-Indigenous said something quite racist, and I'm sitting there on mute, and I'm going, oh, I'm gonna have to say something, right? I'm gonna have to say something. Yeah, I'm gonna have to say something. turn my hand up. Yeah, that was kind of racist, blah, blah, blah. And I was getting ready for the sort of, the gaslighting and the, oh, that's not really what I meant. But I was just about to say something else, and this non-Indigenous fellow put his speaker on, because she was saying, well, I didn't really say that. And he goes, oh, you totally said that. And I was like, honestly, I was almost in tears. I was so moved, because that's the first time in my entire career that an ally has stood up with me directly in a meeting and said, no, that was actually racist. And so I encourage each of you to think about that and what it meant to me, and how it changes dynamics of groups, and ripples go outwards. So if you can do it yourself and you can participate in that speak up culture, the ripples will be felt in many places that we can't even comprehend the extent of.
Dr. Redding, Dr. Wieman, this has been, I have to say, one of the privileges of my career so far. So thank you for the opportunity to be here with both of you. Thank you to Gairdner. Thank you to Dr. Rassant. Thanks to Rob, Amy, the ICAM group for helping us. I'm forgetting people, I'm sorry. And thank you thank you to all of you for being here and for engaging today. I hope it's been a helpful conversation and it's certainly been a meaningful one for me. So miigwech, and safe travels to all of the places that you're from.